Welcome, focused learners. Today, we're bringing absolute clarity to the highly detailed NICE guidelines on intrapartum care. If you're looking at your childbirth choices right now and feeling totally overwhelmed by the sheer volume of information out there, you are definitely in the right place. Our goal with this explainer is to translate all this comprehensive clinical data into an empowering, easy-to-understand toolkit for your birth plan decisions.
Just so we're all on the exact same page, every single piece of data, every stat, and every recommendation we're diving into today comes straight from the National Institute for Health and Care Excellence. You probably know them as NICE. And before we even get into the weeds, I want to highlight the most reassuring takeaway from these guidelines. For low-risk women, giving birth is generally very, very safe for both you and the baby. Keep that solid foundation of safety in mind as we explore your options. Medical guidelines can definitely feel dense, so to keep things simple, we've broken this down into a quick 5-step roadmap. The power of choice, your 4 settings for birth, first versus next birth, understanding transfer rates, and finally, factors influencing your choice. Let's get right into it. All right, Section 1, the power of choice, and why having this information is literally power. This brilliant quote sets the tone for the entire document. The guidelines emphasize that making and recording your care choices in advance gives you the time you need to really process everything. But honestly, here's the absolute best part. You're completely free to make decisions and then change your mind at literally any time. Seriously, even right in the middle of labor. Your birth plan is a flexible, living document, not some unbreakable contract. Moving right along to Section 2, Settings for Birth, and looking at your menu of options. The guidelines is super clear that commissioners have to make sure these 4 specific environments are available to everyone. You've got your home birth, a freestanding midwifery unit, which basically just means it operates completely independently, an alongside midwifery unit that's attached to a hospital but still run entirely by midwives, and finally, the traditional obstetric unit, which is your standard doctor-led hospital ward. You are completely entitled to pick any of these, provided they're available in your local or regional area. Okay, Section 3. First birth versus next birth, and this is where we start to see how the numbers diverge. We just need to quickly define a couple of clinical terms you're going to hear a lot. Nulliparous simply means a first-time birth. Multiparous means subsequent births, so basically you've done this before. Knowing which camp you fall into is actually super important because the statistical outcomes for where you give birth look pretty different depending on your history. Let's compare them. For multiparous women, again, those who have given birth before, planning to deliver at home or in a midwifery-led unit leads to fewer medical interventions. We're talking fewer episiotomies, less forceps use, and absolutely zero difference in outcomes for the baby compared to a hospital setting. But for nulliparous women, or first-time moms, the story changes just a bit. You still get those fewer interventions outside the hospital, but if you're planning a home birth, there's a slightly different risk profile for the baby. And here is the crucial number. The data shows that for low-risk first-time moms planning a home birth, there is an overall small increase in the risk of a serious medical problem for the baby. So exactly how small are we talking? It's about 4 more per 1,000 births compared to other settings. It's a very precise, tiny fraction, but it's there to help you weigh the undeniable comfort of being at home against a really marginal increase in clinical risk. That brings us to Section 4, understanding transfer rates and the reality that sometimes plans just have to change. Now, what is super interesting here is looking at why transfers actually happen. I mean, when we hear the word transfer, our brains immediately jump to blaring sirens and massive emergencies, right? But look at the data for home birth transfers. A massive 32.4% are simply due to a delay during the first or second stage of labor. It literally just means things are moving a bit too slowly and you need a little more medical support to help the process along. It's not always a crisis. Because these transfers absolutely do happen, whether it's for a delay or maybe you just decide you really want an epidural. The guidelines practically beg you to ask your care team about this stuff well in advance. Have that chat, ask about local transfer times, what a delay in care actually looks like, and the plain old logistics of how your birth companion is going to get to the hospital if you are riding in an ambulance. Figuring out those what-ifs early completely removes the panic if your plan has to pivot on the big day. All right, our final section, Section 5. Factors influencing your choice, and taking a close look at individual risk profiles. A huge factor the guidelines point out is body mass index. The data tells us quite clearly that a higher BMI at booking, specifically anything over 35, does bump up the likelihood of complications, like needing an unplanned cesarean or dealing with a postpartum hemorrhage. And if something like that does happen, advanced care can be given way faster in an obstetric unit than at home or in a freestanding unit. So your BMI is just a really vital piece of the overall planning puzzle. This brilliantly illustrates how pre-existing medical conditions fit into that framework. If you have confirmed cardiac disease, or asthma that's landed you in the hospital, or diabetes that requires medication, the guidelines strongly suggest that an obstetric unit is your safest bet. It's not about taking away your choices. It's really just about making sure the specialized doctors are right down the hall the absolute second you or your baby might need them. In that exact same vein, the guidelines neutrally lay out that certain things popping up in your current pregnancy will also shift your risk profile toward an obstetric setting. We're talking about expecting twins or multiples, having placenta previa, developing preeclampsia, or dealing with substance dependency. These are clinical flags. They just mean a higher level of monitoring is the absolute standard of care to keep everyone safe. But let's bring this all back to you and your care team. No matter what your risk profile looks like or what choices you're leaning toward, the guidelines are incredibly strict about this. Your healthcare professionals must remain completely neutral. They are explicitly told not to drop their personal views or judgments onto your choices. Their only job is to give you the data, break down the risks and benefits, and fully support whatever informed choice you make, period. So we're going to leave you with this to chew on. How will having this data change the conversation you have with your midwifery or obstetrician team? Take this explainer, use this knowledge as your personal empowerment toolkit, and start asking the precise, localized questions that are going to shape your perfect birth plan. Because when you know the data, you hold the power. Thanks so much for joining me on this explainer, Focused Learners. I'll see you next time as we decode another vital topic.